So I'm going to go through the three main procedures one by one: the sleeve gastrectomy, followed by the gastric bypass, and then the duodenal switch procedure. And as I do this, I'm going to show you on a diagram because it's a little bit easier to explain what I'm talking about as you're looking at a diagram. I will, however, caution you, don't choose a procedure based on the way it looks in the diagram. A lot of people get concerned because they say, well, the bypass procedures are really confusing to me with the rerouting of the bowel, and I don't think I want all that going on. The reality is you probably don't know what your GI tract looks like right now. All of these operations have been done hundreds of thousands of times, and people do very, very well with them, so don't get caught up in what they look like. I'm showing the diagrams more so because functionally it's easier to see what I'm talking about than to try to put it together in your head. So let's start off with the sleeve gastrectomy. So obviously a very popular procedure. Here in the United States, it's really been done on a wide scale over the last 12 or 13 years. This operation, we're just going to operate on the stomach. We're not going to touch the small bowel. As you can see, we remove 3/4 of the stomach. This is done by placing a measuring tube or a calibration tube during the surgery down inside the patient's stomach. We take a surgical stapler. We use that to measure how much of the stomach we're going to leave behind. We remove about 3/4 of the patient's stomach, and that actually comes out of the body, leaving behind this narrow tube of a stomach. Doing that will kick off the metabolic response that many of you have heard me talk about, where the body will actually internally want to reset how much body fat that patient has. What does that mean? Well, the patient's going to wake up from surgery obviously weighing the same amount as when they went to sleep, but internally their body has reset to a much lower weight, and they will automatically kick into this hypermetabolic phase, or the honeymoon phase, as you hear many people talk about it, where their metabolism is cranked up, their hunger hormones go quiescent or quiet, and this process will last about a year as the patient's weight is shifting back down. Now, functionally, once the food passes through the stomach, it's going to enter into the small intestine. Most adults have about 6 or 7 meters of small intestine, and this is where all of your absorption of nutrients takes place. Nothing's absorbed in the stomach and nothing's absorbed in the colon other than water, so most of your nutrient or all of your nutrient absorption takes place in the small intestine. Because we have not bypassed anything, this operation allows the patient to absorb everything that they eat. The upsides of that are that there's relatively little worry about vitamin deficiencies or nutritional deficits, but the downside of that can be that the patient is going to absorb everything that they eat. And if that patient begins to stray away from their prescribed post-bariatric diet, you're going to see the result with fairly rapid weight regain. So statistically, this operation does have the highest propensity for weight regain. Because of this long, narrow tube of the stomach, which is a high pressure system compared to a regular stomach anatomy, this operation can also lend towards the development of gastroesophageal reflux or heartburn. So over time, over 5 to 10 years following this operation, sleeve gastrectomy actually has the highest reoperation rate of the other operations I'm going to talk about, and that's been shown to be around 17%. And the reasons why most people will have to go back to the operating room after this operation is because of the development of gastroesophageal reflux and or weight regain. So this is actually a very good operation for those bariatric patients in the lower BMI area, with the ultimate goal of getting down to a body mass index less than 30 kilograms per meter squared. If you're beginning with a BMI somewhere in the 32 to 45 or even up to 48 range, I feel pretty comfortable those patients can get down into that safe weight range with this operation. As your comorbidities start to build up, such as hypertension, diabetes, sleep apnea, things like that, or your BMI gets closer to 50, you may want to think about another operation that's going to give you a better opportunity to lose that weight and keep it off over time.